Thank you, Gregor, and some interesting insights there around what drives our social context. And just to say that the document referenced around prevention is on the member site now. So I'm going to move straight into our next presentation, which is a joint presentation by Richie Stafford and Karen O'Connor from the Department of Health, setting out under the drug strategy the issues around prevention. And I think Richie is the podium first. Richie, you're very welcome, and again, ask you to keep the time. Thank you.
Okay, morning everybody. I suppose we've probably all heard the phrase that prevention is better than cure. So the fact of the matter is, if we implement prevention well, we reduce the need for more curative interventions. And that's kind of been a theme of the Assembly from what I've seen. We've had Giovanna Campello in the first weekend. She talked about international standards. In weekend 3, we had Jim Walsh. So Jim spoke a little bit about the work that's going on at the department and the need for evidence-based prevention. But I suppose this slide is something you might relate to at this stage of the Assembly, that drug use is a very complex human behaviour. And I suppose there isn't any real silver bullets, as you've seen up to this point, and prevention is a bit like that as well. Sometimes we think we can kind of give young people inoculation when they're 13 by scaring them the life out of them, they'll never use drugs. It's not as simple as that. So when we talk about prevention, I suppose, in terms of different responses, I believe, and a lot of other people believe, that that should be our first response. So we can divide prevention into universal prevention. That's any prevention activities that look at a whole population, so it doesn't differentiate based on risk. Then we have selective interventions, which would profile people based on risk, and indicated, which would be more at the individual level or small groups. So an example here, somebody you might, if you cycle in Dublin, this is a familiar picture, really poor environmental prevention. So when you have poor environmental prevention, you need more harm reduction, so things like helmets, you see signs in the background, that kind of thing. You go to other places where with good environmental prevention, you reduce the need for harm reduction and other interventions. So as preventionists, we're really interested in prevalence data. So you'd have heard a bit of this, but I suppose, like Gregor said, we look at a whole population approach. So the reasons why people use drugs are very interesting, but the reasons why people don't use drugs are also as interesting. And that's the kind of silent majority that Gregor talks about. And to kind of make sense of that, we use theories around human behaviour. So one of those is the theory of planned behaviour. So that kind of proposes that our behaviour is a result of our attitudes, normative beliefs, and our beliefs around our own controls. They form intentions, and then intentions might be governed by environmental constraints and our ability to perform different actions, and that results in behaviour. But this goes in both directions. If you cast your mind back to pre-2004, if you had walked into a bar in Ireland, you mightn't have seen the other side of the room because of smoking. But it was something we kind of accepted. The smoking ban came in, changed the behaviour, and now the attitudes and the norms have changed massively. If you saw somebody smoking in a bar now, your jaw would hit the floor. So you can see how it's not that straightforward. Again, going back to prevalence data, the SPAD study is something really interesting around youth drug use. So this is a study that happens every 4 years across 35 European countries. And there's just some of the Irish headline data here. What's worrying for us with the last survey is drinking in the last 30 days and smoking lifetime has gone up a little bit for the first time in a long time. So that's something we're keeping an eye on. But actually, Sabrina Molinaro, who's the SPAD coordinator, she gave a great presentation at the National Drugs Forum. So we might be able to make that available for the members. So in terms of national approaches, Chile is, as Gregor mentioned, is really interesting. So they also do prevalence studies. And what you'll see here is they had a massive spike in cannabis use over about a 4-year period. This coincided with their choice to decriminalise cannabis use. It's not as simple as saying that decriminalisation caused this, but it's around those descriptive norms that there was a lot of debate in the media. Cannabis use went up massively. But what's really interesting is the response. So what Chile did, the first thing they did was they implemented Planet Youth. So Planet Youth it's essentially a survey. It collects a lot of data, but what's important with data is what you do with data. So we didn't see any significant effects in Chile. So they've changed tack, and now they're looking at the Unplugged program, which is another intervention that's mentioned in the Exchange Registry. Very effective. It's a classroom-based manualised program with good outcomes, and it's been rigorously tested across many European countries. But if they could go one better, if they look north to Peru. Peru just published a study earlier in the year that looked at the implementation of Unplugged. In some schools, just Unplugged. In other schools, they implemented Unplugged, but also they trained decision makers in effective prevention. And what we saw there when they did both in tandem, there was much better results. And that goes back to that point Gregor made about having infrastructure. That manualised programs are fine, but if we put the infrastructure around them and train people in what works, we get better outcomes. And I think even before maybe we look at what's beneficial, it's sort of stopping doing the ineffective stuff. So a lot of what's popular is kind of providing information, trying to scare people straight, testimonials, these kind of things. They don't work, and essentially they don't work because of a thing called confirmation bias. So you might have experienced this a little bit yourselves, that we tend to think we're very rational actors and that we hear facts and we act based on facts, but really our values and beliefs shape a lot of our behaviour, and we choose some of the facts that we choose to believe in. So so if you think about a scare tactic, that's great if you find drug use abhorrent, that confirms your beliefs. But if you're a young person who is partial to maybe taking some risks, or you know people who use drugs, you use drugs yourselves, that doesn't tally with your real world experience, and you disregard the message. And scare tactics can also kind of arouse an interest in drug use, which is very unhelpful. So we tend to avoid those. The other thing to avoid really is kind of cohorting people who are at risk around a certain behaviour, because you essentially form a group where the behaviour is normalised and then amplified. So in terms of what's effective, it's not always the simple stuff. But I think the exchange registry, if I could kind of point you towards one thing, given the time constraints, is to have a look at that and maybe see what tends to be beneficial and what isn't beneficial. So just flicking forward. So I suppose the challenge for all healthcare providers is to first do no harm. And that's something that we see in healthcare. It's the work of the Assembly here, but it's also the work of prevention, that our interventions are safe and don't cause any harm. So with that, I suppose we have a few recommendations. Like in Ireland, we're quite good in some respects. We're very good at macro level prevention.
1 minute, Richie, if you can. Just conscious your colleague.
So we're very good at things like legislative changes. So we're the first in Europe to introduce the indoor smoking ban. We have minimum unit pricing. Gregor calls us the Ferrari of Europe because we've made massive progressions in prevention over the last while. So we're implementing the European prevention curriculum. We have our own registry, and the funding programme that Karen will talk about is also really exciting. But I suppose one of the problems is that we have no office responsible for drug prevention. Funding streams are quite disparate, so we've no real oversight of standards. People do different things depending on where you live. We have a network of health promotion improvement officers around the country who have an alcohol prevention remit, tobacco prevention remit. They don't have a drug prevention remit. So that could be something useful we could look at. And then in general, just implementing evidence-based prevention, because if we don't do prevention well, we pay for it in the long run. So with that, I'm going to hand you over to Karen.
Thanks, Richie. Karen, join us, please. Thanks, Richie.
Good morning, everyone. It's great to be here with you today. So look, Richie and Gregor talked to you about some of the key theoretical ideas around evidence-based prevention. What I'm going to do is talk to you about the Department of Health's policy responses, what we're doing now, where we see this work going, and kind of the bigger picture of what we're calling for as well. As the guys alluded to, prevention is a really unique policy area because it has evidence, decades worth of evidence, that tells us what works and how to do it. So what I'm going to get into first is the policy rationale. I think many of you will know now at this stage that we have a national drug strategy, reducing harm, supporting recovery. The first half of this drug strategy did have prevention actions in it, but they were kind of high level, vague, and ultimately that led to them not being implemented very well. We conducted a midterm review in 2001, and the strategic priority one that emerged out of that is on your screen there, but as you can see, we are strengthening the prevention of drug use in the second half of the strategy. Under this priority, we are also working to Article 33 of the UN Convention of the Rights of the Child, which again commits us to implementing measures that will prevent the drug use for a younger population. So I'm going to talk to you a little bit about what we're doing now, where it's come from, and kind of where we see it going in the future. In 2019, a group of prevention workers from drug and alcohol task forces came together and had a conference. They produced this report, which is the first image you see on your screen. This report had some really stellar arguments for evidence-based prevention and to bring a little bit more coherence and structure to the delivery of it in Ireland. At this point, I linked in with Brian Galvin, who's on your advisory committee. Brian directed me towards the European Centre for Drug and Drug Addiction, and a course that they deliver called the European Prevention Curriculum, which you can see there. At this point, the department decided to invest in a number of us undertaking this course at European level. And you can see myself there in Poland a few years ago taking the course with some other national experts. This course really endowed us with the opportunity to form a network of national and international drug policy and prevention experts, including Gregor, who you've just heard from, and Richie here, who you just heard from as well. These experts helped us in the department to devise a prevention funding programme that was geared specifically towards evidence-based prevention. And through further investment from the department, we have been able to allocate 1.5 million towards prevention projects that I think really represent the future pillar of evidence-based prevention in Ireland. So a little bit more about that programme. It's running for 3 years. The programme has funded 5 key projects, all represented there with the logos on screen, and these projects will each get 100,000 a year for 3 years. The projects are implementing prevention across a number of different settings: schools, universities, community, nighttime economy, and deprived areas. These projects are also bringing together stakeholders from across the sectors, from the Department of Education, who you'll hear from next, from the HSE, from NGOs, and from drug and alcohol task forces. And we have some posters, I think, outside on the wall here, where you'll be able to learn a little bit more about these projects. And Clondalkin Task Force will be here with you tomorrow to talk more about their project. These projects were picked because they're innovative, they rely heavily on evidence, and because they're implementing international evidence-based programs like Richie and Gregor spoke to you about in an Irish context, which is really, really important. They really are really wonderful, so I do encourage you to go and have a look outside there. So look, that's kind of what we've been doing so far. So I want to talk to you about maybe our bigger picture, where we're going. Obviously, the department is working towards better prevention. So we're doing 3 key things here to implement this. We're going to work on a guidance framework. And a guidance framework, this is going to aim to really bring some more coherence to delivery of prevention across Ireland. It's going to address issues of standardisation and competency also in the delivery of it. And it's a health-led document, but we are going to work with stakeholders across the sector in its publication. The second part, obviously, is the funding programme, which I've talked to you about already. And we did this so we could ensure that evidence-based programmes could be initiated across the country. And the third part is we are working and will continue to work with our European partners and European experts, including the European Centre for Drug Addiction, the European Society for Prevention Research, and work under the European Prevention Curriculum to ensure that everything we're doing in the department stays in line with the best possible evidence and practice base that's out there. Through doing all this work, we really hope to endow a better understanding of evidence-based prevention across the country, because to be honest with you, sometimes prevention across the country hasn't been delivered in line with the best possible evidence base, and it's really important that we really stick to that, because if we do, the longer a programme like that works, the better payoffs we'll have, obviously primarily in drug use, but in cost impact of drug use as well, because as Richie alluded to, prevention is better and quite often cheaper than the cure. So, the bigger picture here, what am I calling for here today? I am calling for evidence-based prevention to be made a key pillar of drug policy. The work we've been doing that I've talked to you about, it's the first step that we see in the right direction, and we're going to evaluate it at the end of the 3 years and scale up in terms of what has demonstrated a positive impact. But really, prevention, it should be the key part of drug policy, regardless of the legal framework, which I know you guys are debating here, because it sends out a really strong public health message. We're telling people that we care first and foremost about their health. And then on top of that, it's not a nanny state. We're not telling people what to do. We're just giving them the information and the strength to make strong decisions about their health.
Just 1 minute, Karen. Thanks.
Thank you, Paul. Nearly done. So look, that's my key message here today. It's an important area to work in, and it's important because it addresses issues before they might even arise. We will save money, but we may even save lives. And that's what I'm calling for here. Evidence-based prevention, key pillar of drug policy. It's not an ideological choice, it's crucial. So look, thank you very much for your time, and thank you.